Next, Carl Pepine is joined by Dr. Emil Moehler, Professor of Medicine and Director of Vascular Medicine at the Perelman Center of the University of Pennsylvania in Philadelphia, to discuss supervised exercise versus revascularization. Does the CLEVER trial change current care standards?
Emil, tell us what you found and tell us a little bit about the CLEVER trial.
Sure. It's my pleasure to be here and to really represent the CLEVER investigators as a whole. It's a large group, including just a few, Tim Murphy and Alan Hirsch, who were leaders of the study. But it's my privilege to present and talk about the data of the CLEVER trial for the entire investigative group. So CLEVER, or supervised exercise versus primary stenting for claudication resulting from aortoiliac peripheral artery disease, is the title of our paper. We reported the 6-month data. And to refresh your memory, what we found was that when we compared an optical medical treatment group versus an iliac stenting group versus a supervised exercise program in patients with peripheral artery disease, that there were significant changes at the 6-month primary endpoint in walking distance. So the way the trial was set up is we randomized patients with peripheral artery disease who were to undergo an iliac stenting procedure into one of those 3 groups. As far as background therapy goes, all patients receive cilostazol, which is a phosphodiesterase inhibitor that's approved to treat patients with claudication. And then we looked at those 3 groups to see how they would do on a treadmill study, a 2-mile-an-hour graded treadmill exercise study at the 6-month endpoint. And what we found was that the maximum walking time, the time when the patients had to stop on the treadmill due to claudication, was improved significantly in the stenting group, as you might expect, but also significantly in the exercise rehab group. And it turns out the exercise rehab group walked further than the patients who received iliac stenting.
So those were really remarkable findings, as I recall, and we discussed them that way, and you presented them. So tell us now, has the result of CLEVER changed practice standards?
I think if you look back at the PAD guidelines, the ACC-AHA peripheral artery disease guidelines that were published, the Class 1 recommendation was try exercise rehabilitation therapy prior to considering an intervention for patients with stable claudication. Of course, this is different than patients with critical ischemia that deserve almost immediate medical attention. It's like an unstable angina population where they need to identify the issue and treat them right away. In patients with stable claudication, kind of like stable angina is the analogy, those patients deserve an exercise program before intervention. And that was the guidelines, and it still is the guidelines. So actually, I think the CLEVER data supports the guidelines further and gives us more confidence to recommend this in our patients and at least try this approach before we consider intervening.
So tell us now what's happened with the CLEVER patients in the past year.
The study was closed to enrollment, and the last follow-up patient in the study just finished the study in June of 2012. So at this point, we're analyzing the 18-month data to determine, again, if there's continued beneficial effect in patients with stenting and with exercise. So we want to ask the question, if you received exercise for 6 months, is that durable? Will you, again, after 18 months, either stopping or continue on your own at home, if you still have a beneficial effect to the exercise group?
Did the patients have instructions for trying to maintain their exercise program or to recondition or continue their conditioning?
The patients received training by a physical therapist and were guided through an exercise program for 6 months. So they know how to exercise on a treadmill. And yes, they were encouraged to continue if they can, but they did not have any regular follow-up to monitor that nor encourage them of that. They came in for the scheduled visits at the end, but we did not visit their house with a health monitor, for example, or call them. So basically they were somewhat on their own.
So, Emil, I know it's too early, you don't have the data, but just based on your practice, what would your hunch be? Is the exercise response durable?
We really don't know. I think that we're analyzing the 18-month data now. I would hope that sets up a durability issue where it is prolonged. We'll have to certainly look into confounders or whether patients continue to exercise or not, and also to look at the durability of iliac stenting. I can tell you that in the 6-month data, nobody crossed over. No one crossed over to get a stent or an exercise. So I think it'll be a continuous population where we'll be able to answer that question. Namely, is stenting and exercise rehab both equivalent at the 18-month period?
Tell us about the medical therapy.
So the medical therapy worked in 2 different fashions. One, as I mentioned, medical therapy for claudication. That was cilostazol. Patients received 100 milligrams twice a day. And then there was background approach as far as risk factor modification. All the patients in the study were analyzed for their risk, and there were current guidelines that we used to target the level of risk modification. So, for example, if the patient was not on a statin, we would encourage them to be on a statin to lower the LDL cholesterol. If the blood pressure is not controlled, we reached out to the centers, and then they reached out to the referring physician to modify the risk factors. And at the end of the study, we were very pleased to see that the background therapy was very rigorous. Most of the patients were on statins, most of them were on antiplatelet therapy, and they were really well treated.
So what proportion would you say made goals, made blood pressure, hemoglobin A1C, LDL goals?
My memory doesn't serve the exact number, but in the 90% range.
That's excellent. Good. So then the charge that we have, Emil, is should the practice guidelines change, or if they should change, in what direction? And do you have any comments on that, even without the 18-month follow-up data?
Well, I think the way I would look at the data is I don't think there's anything lost by approaching initially the patient and explaining to them that, did you know exercise may help you? And some of the patients are surprised because they think they have a condition like arthritis where actually exercise would worsen the situation. Some of them are actually pleased that we want them to go out and exercise. So I think consistent with the data, I would still recommend this is as a class 1 recommendation more than ever to treat patients initially before you offer them an iliac stent, that they should undergo an exercise rehab program. Now, after that, if the 6 months has gone by and they've found that there's really not a big benefit, then it falls back to a lifestyle issue and whether that treatment would be effective in those patients at that point.
Well, this is wonderful data, Emil, and I thank you. We'll all be looking forward to those 18-month follow-up data, and perhaps we can get you back again to ACCEL.
That would be great. It'll be interesting to see even if the combination of exercise and rehabilitation together helps improve their performance.